Good evening. I am here to talk about postoperative vision loss following non-ocular surgery. A 54-year-old male who presented with sudden painless vision loss in both eyes for 6 days duration. 10 days prior, he experienced chest pain. For that, subsequently he underwent coronary angiogram that revealed 95% of coronary artery stenosis. Subsequently, he underwent coronary artery bypass grafting. On postoperative day 4, he developed blurring of vision in both eyes, for which he was started on intravenous steroids and antibiotics at the cardiac care hospital itself. He presented to us on 9th postoperative day. He is a known diabetic and hypertensive on treatment. His general examination and vitals were normal. His systemic examination and higher mental functions were normal. Ocular examination, his best corrective visual acuity in both eyes, half by 60. His color vision and central fields in both eyes were not accessible. Anterior segment examination showed 5 mm round dilated fixed pupil in both eyes. Posterior segment examination of right eye showed blurred disc margin with elevated pale disc and then pale area superior to fovea with absent foveal reflex, and the left eye showed blurred disc margin with elevated pale disc. The above clinical picture suggestive of bilateral non-arthritic anterior ischemic optic neuropathy with right cilio-retinal artery occlusion. We suggested oral corticosteroids for this patient, but the cardiothoracic surgeon prescribed antidiabetics, antihypertensives and antiplatelets. Optical coherence tomography of right eye showed optic disc edema with a hyperreflective inner retinal layers in the macula, and the left eye showed optic disc edema with normal macula. On subsequent follow-up visits, his visual acuity was gradually improving, and the right eye showed 2 by 60 with resolving disc edema with pallor, and the left eye showed visual acuity of 6 by 60 with resolving disc edema and pallor. Coming to the discussion, optic nerve head supplied by short posterior ciliary arteries, and cilio-retinal artery is a branch of short posterior ciliary artery. Concomitant non-arthritic anterior ischemic optic neuropathy with cilio-retinal artery occlusion is rare. Even if it does occur, it is typically pathognomonic for giant cell arteritis. Our patient had painless vision loss with normal erythrocyte sedimentation rate and C-reactive protein, suggestive of giant cell arteritis unlikely. The mechanism behind this, the plaque released from common carotid artery, it went to the internal carotid artery, thereby blocking posterior ciliary artery. And the second one is marked optic disc swelling, which is inherent to non-arthritic anterior ischemic optic neuropathy, causing local compartmental effects around the disc, thereby compromising the circulation, and then concomitant cilio-retinal artery occlusion. To conclude this, postoperative vision loss in cardiac surgery is a rare complication. Even if it does occur, anterior ischemic optic neuropathy and retinal artery occlusions are occurred. Plaque in the carotid Doppler is more important than the degree of stenosis. Surgeons and anesthesiologists should be aware of the possibility of vision loss postoperatively. There is no proven treatment for anterior ischemic optic neuropathy and retinal artery occlusions. Stabilizing the hemodynamic derangement may be beneficial. Ophthalmologist consultation is necessary. There were few cases reported on perioperative optic neuropathy after cardiac surgeries, that is mostly of bilateral ischemic optic neuropathies, and some cases reported on after spine surgeries. There were retinal artery occlusions. There were one case reported on non-arthritic anterior ischemic optic neuropathy with a cilio-retinal artery occlusion with no causative agents. Thank you.
What is classically reported is the posterior ischemic optic neuropathies after cardiac surgery or very hypotensive episodes. How do you think that would differ from the anterior ischemic optic neuropathies? How would you be able to clinically differentiate the two? What would you look for? What did your patient have which was different? PIO and
yes.
So when there's a hypotensive episode post-cardiac surgeries.
He's a diabetic, sir. The anterior ischemic is most common causes diabetic for non-arthritic anterior ischemic optic neuropathy.
So in PIO you would not get any disc edema.
Disc edema.
It's only in anterior that you will see the disc edema. But a lot of these cases will actually have PION rather than NAION. That's there. But here it was NAIO, and then you are looking for other risk factors or causes. Same, because the surgery itself is a stress
yes.
for the person, so that itself becomes a very big risk factor. Somebody who's even relatively well controlled, I've seen maybe more than one case, in fact, maybe 2 or 3 now, Vedanta would end up with NAION picture. So yeah, that's one of the things.
what I really liked was that you have explained the mechanism by which the pathology would have occurred. So that was really nice. By any chance, did you have access to the pre-op carotid Doppler or the post-op in
Yes, sir.
cardiology?
Yes, ma'am. Carotid
concept?
Doppler, it was showing the left common carotid bulb plug in the left common carotid bulb.